Good afternoon or morning, depending on which side of the pond you're at. Thank you for joining. For those of you who are already here, if you just bear with us a couple of minutes, we're just going to give a few more minutes for other attendees to join too before we get started. Unfortunately, I have no holding music for you, and I won't sing a song and make you all turn off straight away. Great to see so many of you joining already. Some great numbers here. As we are waiting in the chat, it would be good if you'd like to enter in the chat, just where you're from, whether it's the US or UK. That'd be nice to see, just a live poll, just to see whereabouts in the world we're from. Well, I'll start then, since no one else has. Oh, hi, Maribel. I see you, Erin. Oh, nice mixed bag here, 50-50 almost. Okay, we'll just give it another minute or so for everyone to join. And then we'll get started. So I think we'll get started now, if that's okay with everyone. So as I say, good afternoon, and thank you for joining us for the first of our three-part series. Oh, sorry, I'll just start again. So good afternoon, everyone, or morning. Thank you for joining the first of our three-part series today. My name is Oliver Chan, and I've been working with Sherry and the team at Cincinnati for just over 12 months now, supporting them on their Power Platform and EasySPC journey. For those of you who are not familiar with BCN Healthcare, we are a digital transformation specialist based over here in the UK. And part of what we do is support healthcare organisations with their data and reporting needs. We're really, really excited about this series, as for a while now, our healthcare customers have been keen to see what great looks like when it comes to quality improvement. So we've invited Cincinnati Children's Hospital on this webinar with us today, along with Tom at East London Foundation Trust. And Cincinnati have a dedicated QI centre and they're going to be sharing with us on this series, this three-part series, how they're using control charts to support their QI initiatives, as well as other tools in the Microsoft ecosystem, such as Power Apps and Power BI, and other tools to help with their QI initiatives. In this session, please use the chat window, as some of you have done already, to state which part of the world you're from or are in today. But please use the chat window to ask any questions. We'll do our best to get through as many as we can in the Q&A session at the end. We'll also have a live poll at the end of the session too, just to help us understand what are the key topics you're interested in the next sessions, which we'll be covering too. And Sherry and the team will also be sharing a little teaser to what's coming next in next week's session, as well in the session on the 16th in a couple of weeks' time. Okay, so to kick off today's session, before we let the Cincinnati team introduce themselves, we have Tom Nicholas from East London NHS Trust, who's going to be sharing an overview of their SPC journey here in the UK. So over to you, Tom, if that's okay.
Thank you very much. And yeah, good afternoon from London, from Bethnal Green in London. If you're from the US and you're visiting London, Bethnal Green probably isn't on your top 10 of places to visit, but nonetheless, nice to be with you this afternoon. So let me just share my screen with you. And before we listen to the fascinating stuff from Cincinnati, I'm just going to give you a really quick background about the EasySPC tool in Power BI, which we've collaborated with the BCN group, which has really helped us on our quality improvement journey. So at East London, we're 10 years into our quality improvement journey and trying to use quality improvement in everything we do. And a fundamental part of that is supplying statistical process control charts to all parts of the organisation, to the board, to the wards, to the service teams, to clinicians and consultants. And why do we do that? It's because we want every part of the organisation to understand, to be able to look at their data, understand variance, understand trends, and hopefully plan improvements to improve healthcare. So we don't want it to be the reserve of a small population of our trust. So if you're working in an organisation where perhaps quality improvement and statistical process control is a sort of peripheral role, perhaps the role of a few well-meaning projects, or perhaps it's just for the reserve of boards or senior management, the EasySPC tool is no doubt going to be useful to you. But if you're going to be like us and really try and get the whole organisation on that journey, I think the EasySPC tool has been fundamental to us to being allowed to get masses of statistical process control chart data to a wide population. So just a brief look at our design principles at East London for our online dashboard. So you'll see improvement methodology is at the heart. But also one of the key factors for us, as I mentioned, is allowing all parts of the organisation to see that data in that meaningful way. And obviously, the top level is important and also the bottom level, but don't lose the thought that there's so many combinations in between. So you might want to look at an improvement project for a group of wards. You might want to look at improvement projects for a certain set of clinicians or a particular pathway. There are so many combinations that you might want to look at the data as, and that's the power of the EasySPC tool, is you can multiple select your own filters and the SPC chart is supplied for you, ready to go. So a few things that have helped us with the EasySPC tool. So we use Microsoft Power BI. That's the simplest one, and that's obviously compatible. Creation of SPC charts within a few seconds with very little technical knowledge needed. Well, I need to be careful here because my organisation, probably like yours, has some incredibly talented technical experts, programmers and developers. But they're not all subject matter experts of statistics and statistical process control. So the EasySPC has allowed us to bridge that gap of having that programming experience and that developing experience, but having the tool allowing to get accurate and validated statistical process control charts out. It's really helpful for highlighting the special cause variation, the changes and the improvements over time, because like any dashboard, you want to be able to glance at it quickly and quickly understand where to focus your attention, where the change has been made, and the tool highlights that and allows you to drill down on it. Then the final point is baseline and step changes. So as your projects show improvement and you start to apply changes or to it, is you want to do that in a dynamic way, so that wherever the improvement's happening, if it's in a single ward, if it's an entire directorate, if it's in an area or a locality, you can apply that change, that step change at that exact level. So this is the final slide I just wanted to show you, just to sort of prove the point of how useful it's been to us. This is one of our apps for our inpatient wards here at East London. We've got about 100 measures represented as statistical process control. Within those 100 measures, if you were to pick an individual category, an area, a directorate, a ward or a clinician, you can generate 3,000 SPC charts. But if we allow the users, like we do at East London, to self-select any level of granularity or to group wards or specialties together for their own purposes, I can promise you that's not a lie. At the bottom there is the EasySPC tool is creating over 100,000 charts every single day. Now on our journey, we started off using Excel, and of course we still use Excel for certain tools, but I can promise you, as hardworking our analysts are, we couldn't generate 100,000 charts in a decade. We also tried data warehouse solutions, lots of programming, putting a lot of sort of meat overnight into presenting the data, but the truth is live on the fly of being able to select your chart and see your chart. EasySPC's really helped us with that goal that I started this conversation off. So if you want to industrialize, mass produce a good way of looking at data to a wide population, it's been incredibly helpful to us. So I think that's all the time I'm going to take from you for the moment. And now comes the exciting part. I think it's back to Oliver and colleagues from Cincinnati.
Excellent. Thank you so much, Tom. And yeah, great insight there and an overview of how East London have been using control charts on their journey as well. So yeah, over to Blair and Marianne at Cincinnati.
Hi, everyone. It's so nice to be with you this afternoon. My name is Marianne Lank, and I am the Senior Director of Improvement Science in the Anderson Center at Cincinnati Children's. I'm joined today by my colleagues Blair Davis, who's the Director of Decision Science, and Sherry Colady, who's the Director of Data Management and Visualization. There they are. I'd like to start with a high-level story of our improvement journey, as this lays the foundation for where we've been, where we are today, and how we're designing for the future using EasySPC. So first, let's start with what guides us at Cincinnati Children's. And really, our vision is to be the leader in improving child health. Our mission is to improve child health and transform the delivery of care through fully integrated, globally recognized research, education, and innovation. And we're focused on our patients that see us in our community and also those that come to us from around the world. And we want to provide the best medical and quality life outcomes, patient and family experience, and value today and in the future. Quality excellence is our structure for aligning our domain leaders and infrastructure leaders who will work collaboratively across the system to develop, support, and manage that world-class quality that we want to achieve in alignment with our mission that I just described. Blair, Sherry, and I are quality excellence leaders for infrastructure. We manage the teams of data analysts, scientists, and QI professionals and project staff that support improvement efforts in the medical center. The domains are in the circle. Achieving the best patient-centered outcomes is why we're here. Providing best access for our patients and families means delivering the right care at the right time and in the right place, whether that be in person at our medical center, in the community, in the home, or virtually. Experience includes both patient-family experience and employee wellness, and safety is both patient safety and employee safety. We've been on over a 20-year journey of quality at Cincinnati Children's, and that was kickstarted in 2001 when we were awarded the Robert Wood Johnson Foundation Pursuing Perfection grant. In 2004, our Advanced Improvement Methods course was launched, where faculty researchers and quality improvement professionals learned advanced analytics, including planned experimentation, and they began to publish their work. Learning networks began in 2006, along with our flagship improvement leader course called I2S2, or the Intermediate Improvement Science Series. We have a portfolio of quality improvement courses that meet the training needs of all levels in the system. The courses in pink are for our macro and meso system leaders, AIM and I2S2 as I described, and also our Quality Scholars program, which is for our system transformation leaders. Impact U is our community leader course, which started 8 years ago. Oops, skipped ahead there. And that is for folks that are from the health department, public schools, job and family services, and other community organizations and agencies, where they're learning quality improvement methods, applying them to their projects, and their organization, and all of our graduates from our leader courses go on to be coaches and sponsors for other efforts in their areas. We have 2 courses for microsystem frontline teams. They are RCIC, or our Rapid Cycle Improvement Collaborative, and a Lean Collaborative, which is really aimed at reducing burden and waste. We have several e-learning modules for individuals to learn the basics of quality improvement and measurement. So QI is embedded in our culture throughout Cincinnati Children's. Our improvement science framework is the model for improvement, which is described in the improvement guide text, along with the healthcare data guide. You may recognize one of the authors on this webinar today. I think I saw Lloyd Provost join. Hi, Lloyd. Thanks for continuing to guide us and our leaders at Children's. Dr. Deming's System of Profound Knowledge provides the important lenses by which we lead improvement: theory of knowledge, appreciation of the system, psychology of change, and understanding variation, of course. Now I'm going to hand it over to Blair, who's going to go deeper on how we use our improvement science foundations and statistical process control in our hospital improvement work. Thanks, Blair.
Great, thank you, Marianne. Welcome, everyone. All right, let's dig in a little more. Figure out how to advance slides. Does that work?
Yeah, that worked.
Okay. Do you see all of the notes and everything?
No, just your slide.
Just my slide. Okay, thank you. Just checking. I never can tell. All right. So Marianne, as she said, I'm Blair Davis, and I am here representing a extremely talented group of analysts, decision science, data science. It kind of depends on where the trends for titles are. It's a very talented group, as Tom was talking about his group as well. They do all sorts of magical things, and really what it is telling the story. What are we able to learn from the data? You all know data for data's sake is just a bunch of bits and bytes and not helping anyone care for patients in the way that we want to. So how do we decode this? How do we pull it apart? How do we put all of this to use? How do we take talented team members and well-intentioned team members and support them in day-to-day improvement and helping the patients that come through our door every single day? So looking back at the model for improvement, we have these really important questions, right? So what are we trying to accomplish? If we're not sure of that, we're not going to get very far. So we use our evidence. We look at the guidelines. We look at what has been published for what we're trying to accomplish. The next part of how we know change is an improvement. We can do stuff, but are we doing the right things? Are we doing it at the right time? Are we doing it consistently? And then that builds into what changes can we do to make an improvement, and testing that again and again. So going through that PDSA cycle. Now today, I do want to focus with everyone on the measurement part. How will we know that change is an improvement? And so this is really where we develop measures and drives our need for the use of SPC. So digging in a little more, not measurement for measurement's sake, but what's important? What can we use in healthcare? So some of the outcomes we might use are, is a patient able to keep their diabetes in control? Or some things that are more important to the patients themselves may be, how many days am I able to go to school? Or how many days am I able to go to work? Or how many days do I have without debilitating pain? Something like that. We have the contributing processes as well. So are we on the therapies that are needed? Are we seeing our providers at the frequency that's recommended? Are we adhering to different guidelines? Those types of things. And don't forget your balancing measures either, because sometimes when we optimize part of the system, it causes chaos in other pieces of the system. So understanding if we're really trying to do timely discharges of patients and get patients through our system, are we causing more stress on readmissions? Are we seeing more patients need to come back to the emergency services and use those care when we could have better supported them in the initial hospital admission? So some of those balancing measures as well. And then we also have all or none, right? Are we doing the bundles of things that we need to do? Are we following guidelines? Are we consistently implementing things? So just a couple of measures that we found that are really helpful in healthcare. So, again, starting to look at the data. So once we have these measures, let's understand and dig in a little more. We have some point in time data, right? We can do a histogram. We can see, are patients experiencing the care that they're receiving in a consistent way? Is there a lot of variation? Do we need this to be higher on the scale? Do we need and expect this measure to be lower on the scale? What do we need to do to intervene to get where we want to be with this? So instead of point in time, let's look at it over time. So we start measuring, we start looking at what is happening over time. Are we seeing a lot of variation? We start with run charts, right? Just start where we are, start collecting some data, look at it in a temporal way. So we go from point in time to over time, but we're still not quite sure. Is this where we want to be? Like for this chart, up is better, but are we able to get there? So we continue to measure, we continue to put in interventions. So after the first few points, we kept collecting data. We put it on another chart, and we're able to see that our interventions, highlighted in yellow here, were able to shift us in the direction that we wanted to go. But again, we still want to be a little more understanding, is this what the process we're expecting? So for patient populations, clinics, I'll say wards, or other groups, we don't use a single measure. As Tom showed, there's so many, and the number can get very large very quickly. We develop multiple measures to improve or track care for processes and against standard guidelines. So we develop charts to measure and answer questions around if we're reliably providing care and are we improving outcomes. So for this example, we'll take a look at some of our sickle cell population. So as you can see here, this is their outcome measure, and it's kind of just going along. So we need to dig in a little more and understand more what's happening. So we may have a suite of measures where we look at different processes that we know impact their care. So are they coming to clinic visits? So we have, what's their rate of no-show? Are they on the therapies that we know have an impact on this condition? So are we prescribing that? Are we providing education to help families really understand what this drug does? And are we doing other scans to help prevent and watch out for potential issues with them? Past that, we know that this patient population is at high risk for admission with serious respiratory issues. And so we want to look at that outcome. And then the contributing guidelines that we know, like, are they being screened? Are they being given a really low cost, very effective prevention when they are admitted into the hospital? So again, this quickly gets busy. Where do we focus? A lot of times, when you get this large and complex, where do all these measures come from? I can tell you, there's not one single person doing every one of these. So they're coming from a lot of different places. Do they easily tell their story together? So if I am one of the clinicians who is caring for these patients, can I easily look at once I get all of these charts together, can I easily understand the story that they're trying to tell? You know, where do I find them even? Some may show up in email. Some may be in a different report that I need to go and self-service, pull myself. So given everyone's best efforts, there's similarities in some of these charts and others look very different. I mean, they all have our Cincinnati Children's logo on it, so we've got that going for us. They all have directional arrows, so I know if up is good or down is good. But, you know, the top middle one even has our Good Housekeeping seal of approval, which means that it came out of, you know, someone from my team. But they have different colors. You know, am I supposed to be able to read these colors? Do they mean something different? Some have annotations about what made that change possible, what influenced that measure, and others don't. Some are in separate Excel files. Again, not knocking on Excel, but that's kind of where they're living right now. The three at the bottom, they all live in one Excel. So at least I can find those together. But at the end of the day, they all probably end up in a PowerPoint presentation that's used at a monthly meeting or a weekly meeting that someone else is trying to put together. And you have to pull them all together. So again, even as much as QI is ingrained in our culture and people want and use this data, it's not always the easiest to get it to them. And then even back to Marianne's point about capability building, a number of these were built as projects. So the ones on the right-hand side were an I-squared S-squared project. The care algorithm for how to care for acute chest syndrome is along the bottom. And so again, we are reusing what comes out of those building block courses, but it's not always in the easiest way to digest and continue to use. We have done some work over the years on standardized views. So this is the standardized views of some of those ones that I just presented. Again, this is a homegrown tool to share charts. We've been loving it since 2012. It's using SSRS and some SQL Server backend. So again, we kind of duct taped and band-aided it together for a while. But again, we have direction arrows. Here you see that there's consistent color. We can easily read from one chart to the other. We know what to expect and where to expect it. However, we didn't have really good flexibility. On the last slide, you saw some chart stratification by age. Once the clinicians realized that their education interventions depended on if the patient was taking the medication themselves, or if they were a younger patient and their families were in charge of that. So the interventions for different age groups needed to be customized. So our standardized tool doesn't allow for that flexibility as easily. So, and again, you're not seeing control charts here. So we really want to get to SPC charts if we can. And Sherry might look at me sideways, but the control charts are here, but it takes me another click. So again, just another reason that you can get to it, but it's not there from the beginning. So it takes a little more effort. Now we did also in here are able, it's an eye chart, right? But the tiny measures there, these are some system-wide ones that we can easily add in. So about your ward, about your unit, about your provider. So these are system-wide measures about safety and experience, some of those overall domains that Marianne was mentioning. Oh yeah, here's no-shows from the last one. So we do have some control charts there. Okay, so this gets to some of our challenges and opportunities, right? At Cincinnati Children's, we didn't have a standard visualization tool. There were a lot of workarounds because of the limitations of our homegrown tool. So I could go and list probably 5 other newer technology visualization tools, but I won't quite plug them here. And there'll always be a need for quick and dirty prototyping. So again, not completely discrediting Excel. We do know and love that to get started. We use it as our gateway SPC tool, I would say, to get everyone hooked. So again, as they're learning methodology, they're also not trying to learn a new tool at the same moment. But for ease of use, we had multiple visualizations, and they're not good at SPC. It's really hard. You needed individual programming, and it would be hard to shift center lines, and it would be hard to add annotations and keep them attached to dots and those kinds of things. So again, that was a limitation, not having a standard tool. For our homegrown tool, we had limited templates as best we could, and building on it since 2012, it was just hard to find the time and resources to build in it. We did build the main charts, but we missed out on having some of the ones that we use as well, X-bar S's, special charts for time between, especially for safety events and those kinds of things. We did have run charts, U charts, P charts, those kinds of things, which was very helpful. Again, moving along in our QI journey, but it wasn't supporting us in the way that we wanted to anymore. We had a huge list of enhancements. I mean, I know this time of the year, a lot of people are starting to put together wish lists, but it was hard to get time or bandwidth to make updates, and any bandwidth we had really went into maintenance and band-aids, to be honest, as opposed to adding in and knocking down our list of enhancements. So that's where we were, but let's go to opportunities, because I'm more of an optimistic person and I like this part better. So I mentioned we've been loving our homegrown tools since 2012, and the computer tools don't last that long. Our app support team was very interested in, as part of our digital transformation, what could we do next? What would support our needs, but would also keep them from having to maintain the old system. So they really pushed us, look at what's out there. Can we buy something instead of building something? Because we know what the maintenance is on that. And so we said, sure, we'll take a look, but we haven't been really successful of finding anything. So over the years, we've looked at many tools, but we hadn't found that solution that could do what our homegrown system could do, even with its limitations. Sometimes the tools wouldn't follow the methodology. Again, a lot of times the control charts had to be individually calculated. So one of the push, as we were looking at new visualization tools, Cincinnati Children's is a Microsoft shop. So we started looking at Power BI again. We had evaluated it in 2014-15 and it wasn't able to function how we needed, but we decided it was worth another look. Again, that was part of the stack that we already had at the hospital. We also wanted to look at reuse of measures. So in our older system, it was hard to have the same measure on multiple reports. You could get single charts, but grouping and reusing was a little more difficult. And so again, as Tom was saying at East London as well, the reuse is really important. Being able to get the output, the charts, the measures to who needs them in the organization is really important. And a lot of times those are different views. Those are different users for different reasons and different frequencies even. So we also wanted to look at additional capabilities. Again, we had this huge laundry list of what we wanted to add in there. So with the newer visualization tools, we wanted to see what we could find. So it was time to pull out the wish list. This is one of my favorites. So I'll wax nostalgic here for a second, but I really, this last year with BCN and EasySPC has really been, it started with a game of telephone. So we had this need we were going through digital transformation and looking at new tech at Cincinnati Children's. We had our old databases. We had all of our measures that we've been developing over years. We had our North Star Healthcare Data Guide. And so we went on a search. Is there something out there that we could implement and will fit our needs? So we started looking for new tools, and literally within a week, I think a few things happened. I got an invitation to attend a lecture that was hosted here at Cincinnati Children's by a doctor who was going to share something about SPC that he was doing for QI in London. So, you know, you get all of these different lecture invitations. I responded tentative. Then I got an email from my boss who had just had a conversation with Lloyd, and he mentioned working with a group in the UK about some SPC charting tool. And so I love a good puzzle, so I started thinking about it, and I'm like, I'm going to need to look at that invitation again. Turned out it was Dr. Amar Shah, who is coming to present a lot of what Tom just shared with us about EasySPC tool. He was coming the next week. So I cleared my schedule and make sure I went to see that. And so again, got a little peek behind the curtain to understand, okay, there's shifts on their center line. Okay, they set annotations and these kinds of things. And so it really piqued my interest. And Dr. Shaw shared that Tom and Taryn and Oliver were all going to be down at IHI. So I called Sherry and was like, we have to go see them. And I think Sherry had a meeting scheduled like probably the next hour. She's on top of that. So anyway, we did bug them down at IHI. At this point, we had evaluated enough tools and had talked to enough of our colleagues about what they were using and what they had experienced that we could find holes in these solutions after a few pointed questions. Or Sherry would start asking questions about how we could potentially implement it on our tech stack. And a lot of times that would discount it as well. So they did have an unfair advantage at IHI because they brought cookies. So I'm always, you know, a sucker for food. Shameless plug there. But they also said, well, this is based on the healthcare data guide. And I think I almost fainted because I've never had someone start talking about visualization tools and really grounded in the same methodology that we have. You saw a few of the screenshots, and if you haven't seen it before, the interface is slick. It integrated with our tech stack, and it followed our charting standards. Center lines could be shifted. I continue to harp on that because it's been such a difficult piece. Annotations were there. They talked the same language that we did. There were I charts and P charts and these kinds of things. So after hearing Tom's presentation at IHI and what East London had shared again, we knew it was worth a try. So the past almost year, we've enjoyed working with the team and started our EasySPC journey. So again, we've been doing it as we've been implementing Power BI. So I'm not sure that I would recommend that at the same time, but we've made it work and found great value in it already. So hopefully we'll see you next time at the next webinar where Sherry will share more about this and we'll dig in even further. But this is a little bit about our build up and why SPC is so near and dear to our heart. And we're excited to continue to journey along on this tool. All right, to the polls.
Excellent. Thank you for that, Blair. That was really insightful. Some great content there. So please do, everyone, as you've got questions, please pop some questions in the chat as well. And we'll look to get through some of those in the time we have remaining. As I speak, I believe a colleague of mine will be entering a poll into the chat too, just to help us and Cincinnati gauge which are the key sort of topic of interest that you'd like to cover, see covered on the next series, which is this time next week. Sherry, as we're waiting for that, is it worthwhile just sharing a little bit about what you're going to be talking about next week on next week's series?
Sure. It was part of the poll, but I can give a little bit. Hello, everybody. I'm Sherry, co-lady. Some of you may have heard of me before joining today, so all of it is true, every bit of it. So next week we are going to be talking about, thank you, perfect timing, selecting and customizing EasySPC. And what we'd like to know with these topics in particular from the audience is which of these items are the most intriguing and that you would like us to go in a little bit deeper so we know where to focus our efforts and give you a little bit more detail than we typically would had we not gotten this input. So we have selecting and customizing EasySPC. Blair went into a lot of that today with regards to the why we decided to pull the trigger and purchase our license. But there we can go into a little bit more detail around that if you need to if you're in that part of your journey and you're deciding as to whether or not you want to move forward with that as a product. We're also going to touch on some integration with existing hospital systems, training and change management, and then real-world outcomes and impact. We've already used this. We have a template that we established in partnership with BCN, and we rolled that out across the organization, and it's been utilized pretty heavily already in especially the most recent months. And we have really great examples that we've already implemented EasySPC and the template, the Power BI template with, so we can go into a little bit more detail around that with item number 4. And then Matthew, if you want to advance to the next one, I don't know if you have or not, but we're also interested in if there's anything else. Are there other topics related to this and your journey that you'd like us to touch on? Is there a particular subject that you'd like to hear from us on? Or Tom? Tom has been doing this longer than us, so. Once we get into webinar 3, we are going to, and I don't know if I'm supposed to do this, but I do shoot from the hip quite frequently. So the webinar 3 is going to be a really big focus on our next steps and our vision and how we're going to at scale implement this work in our QI portfolio across the organization. And it's going to be not only about EasySPC, but it's also going to be Power Platform as a whole and utilizing that suite of tools and really maximizing the tech and utilizing the tech to really move and bring insights to the quality improvement projects that are happening in the organization at scale. Anything else, Ali, you wanted from me there?
No, that was great. Thank you.
All right.
Yeah, no, that was great. Thank you. So as we move on to the Q&A, then, as I say, please pop them in the chat if you prefer to raise a hand and unmute and even turn your cameras on if you like. Then please feel free to do so. And we've got a bit of time now for any questions or comments. If you'd like to share a little bit about what you guys are doing in your healthcare organisation with control charts and quality improvement too. Yeah, this is a great forum for this. We've got some experts on the call amongst you today, which we may be able to lean on. Whilst we're waiting for that, I guess, Blair, there's quite a few things that you touched on there. I know that I've got a few questions, I guess, but I'm also conscious that I don't want to spoil things for what Sherry and Marianne are going to present in the episodes to come too. I guess one of the questions I have then is how well adopted is our control charts at sort of at an exec level at Cincinnati Children's? You know, you've mentioned obviously the Anderson Center and the great work you guys do from a QI perspective, and it sounds like at least that the Anderson Center has a very good grasp on control charts. I was wondering how does that suit elsewhere in the organisation at Cincinnati Children's outside of that sort of QI remit, if that makes sense.
Which one do you want, Marianne, to start with the expectation and the leadership teachings? Okay.
Yeah, thanks, Oliver. I think that because we've been doing this for a while, it's really part of our vocabulary is using control charts. And as I described some of our courses that we offer, like our frontline leader, our frontline team courses, we just teach run charts. That's sufficient. In our community leader course, that is also sufficient. But folks quickly graduate to control charts because they get that sensitivity. And it really is part of how we do improvement. And so as an example, we're going through our operational excellence strategic planning process this fall for the next 5 years. And this is really, I think, the first time that we've seen our quality folks really at the table as part of that goal setting process. And it is an expectation that we will all be setting goals and using measurement and statistical process control and improvement methods to reach those aims. And so I think that really speaks to, I think, where we are as an organization. And it's been fortunate because it allows us, I think, to move faster because folks are expecting to lead with data-driven decision making. But we also have new folks in the organization and new leaders. Their expectation is to go through our leader courses or our team courses, so they get up to speed as well. It's not really an option to opt out, I would say. I don't know if you'd agree, Blair and Sherry, but it's just the way we do things.
Yeah, I was going to say I was typing it, but I'll say it. One of I think the key indicators that QI is really ingrained in part of our culture is if you were to present your data to our trained leaders who are trained in QI methodology, if you were to come to them and present the data in a run chart, they would say, that's really nice, but where's your control limits? Where's the control chart? So they would ask for it. They'd put you on the spot and they'd want to see that. So for me, there's very rarely do I go to a meeting where that question, if the data is not presented the way that they expect it to be.
I think the other thing that it really helps us is to focus, right? So it gets away from common cause variation and reacting to that, either celebrating, thinking that something has improved, or not knowing when something is degraded and seeing the signals for that as well. So using the SPC helps us understand, is this expected, right? Or do we need to check out what's happening and either make an intervention to get it back on track or to keep it, progressing to where we want to hit those goals like Marianne was talking about? Or is it just common cause variation and you're kind of in a wait and see at that point?
Excellent, thank you for that. And I guess one more from myself then. So Blair, you mentioned quite a bit around the technology, the different tools that you were using over the years. How important was it that the technology was aligned to the exec vision and the objectives for the organization?
I would say it depends on who's paying for it, right? So, I think that's what has happened. We've had tools in the past, so we were able and fortunate to build something to try to support our need, and that was difficult by itself. We had tried to use other visualization tools that weren't supported by the enterprise, by the whole hospital system, and so then we would have to foot the bill for some of those licenses. And again, there were times where they just wouldn't quite cut it. The visualization may look beautiful, but it didn't follow our methodology. So time and time again, we saw roadblocks to implementing other tools to try to do this. And that alignment with the tools that we had and were to be supported by enterprise resources really made integrating EasySPC possible. And again, with that focus on the methodology, we didn't have to, you know, try to arm wrestle you guys into saying, yeah, we need annotations. I can't tell you how many times I've had that conversation. They're like, you need what? I'm like, I need a text box on a chart. Yeah, you know, so it's a lot of these things that I really appreciate, not having to feel like I'm educating you on the methodology that we're trying to make standard practice.
Well, thank you for that, Blair, Marianne, Sherry, and Tom. I think we all get 10 minutes back of our time. Thank you everyone for joining today and your response in the poll too. That's going to be really helpful for our next session, our next 2 sessions. So please do join us next week too, same time, same place, and feel free to share it with any colleagues that you think it may be of interest to. But yeah, goodbye for now.